we are trying to move in medicine in general from invasive to non-invasive techniques. Do you think in the future, the high resolution image can replace the invasive nature of biopsies in general and kidney biopsies, particularly? Now we have, like when it comes to bone, for example, we have high resolution QCT that can give us details at a micro level, not at millimeter, but a micrometer level. Do you think this can happen in the future with improvement of the technology and having better and better high resolution image?
Bone disease by imaging, does it depends on density of the bone in different density of bones in different diseases?
When it comes to kidney biopsy, can it be replaced in the future?
This is not the case with the kidney, with the soft tissue. Imaging of bone depends on the density, different densities, but this is not the case in tissue diagnosis.
So you don't think this can happen in the future?
I don't think
there have been some. Can I just comment on? There have been some work on the elastography on the kidneys, which gives some hints, but still very preliminary data. It might help to know whether the kidney is heavily infiltrated with some things or sclerosed or whatever. But the details of the biopsy, the presence of immune deposits, the locations, I think is still, we are early to judge these things.
Yes.
Thank you so much. Another question in the chat box. How many glomeruli usually need to have in the kidney biopsy to have a good judgment?
It differs. It differs. Sometimes one glomerulus is sufficient. For example, in cases of nephropathy. So in IgA nephropathy, if I can, the serial section, I can do the deposits in amyloid. Some cases it is sufficient to get one glomerulus. Sometimes in the cases with activity of the lupus, we find glomerulus with necrosis and hyaline thrombi and wire loops, but it will not be sufficient to grade the lesion. But to diagnose, I can say something. I can say something for the patient. If I find some tubules which are injured besides the glomeruli, I can say that there is acute tubular injury. I can say that this is a membranous nephropathy or IgA nephropathy. But in cases, for example, of focal segmental glomerulosclerosis, I need larger number of glomeruli. So it differs anyhow, but they said that 10 glomeruli are needed. But if I have a biopsy with 6 glomeruli or 7 glomeruli, can I say that it is insufficient and I will not make a diagnosis? No. I will say I will write my diagnosis. So it depends.
Can I give an opinion on that?
Yes, sir.
Of course, as Dr. Hotman say, she can put a diagnosis and say amyloidosis. She can say this is mostly active lupus. But for treatment-wise, I have to know that it's a large area of tissue to look for how chronicity is the lesion, how much is the tubular atrophy extend, how many other glomeruli are sclerotic. So I can say this is membranous, but to give a treatment plan, I need to say how extensive the lesion is, how the chronicity factor is there. So still we need, yes, I can say, I can put a diagnosis, but treatment-wise, prognosis-wise, I have to know the detail of a good number of glomeruli, as Dr. Hotman said, at least 10 glomeruli and 2 vessels.
Very good, very good. Thank you for the clarification. Okay, I think if anyone from the co-hosts or the audience have question, we can, Dr. Fatma can try to answer it. If not, we are going to move to the next presentation.
We have a question
from Professor Peter Sawaya, Dr. Amr.
Okay. So Dr. Sawaya.
Yeah, I'm just curious. In Egypt, would you do the 3 staining the 3 studies, light microscopy, immunofluorescence, and EM on every biopsies? And I from our discussion as we were preparing for this conference, I had the impression that you don't. But in that situation, how do you triage the tissue? I mean, you are doing the biopsy. The preservation for each study is different, the tube and different ways. How do you deal with it? I'm talking about practical thing here. I'm curious to know.
Most of the biopsies, we do the 3. This is the light microscopy, immunofluorescence, and electron microscope. Immunofluorescence, we do it on paraffin sections. I take 15 serial sections from the start of the processing. 15 serial sections, paraffin section, in order to be able to do immunofluorescence by and retrieval by the enzymes, protease, electron microscopy. I divide the biopsy under vision before processing and take a small part for electron microscope. And as I can, I do the 3 techniques.
Very good, very good.
Thank you.
Okay. Dr. Nagy.
Can I add something?
Yeah. Go ahead, sir.
Yeah. Actually, as a clinician, when I was beginning, for me, I thought light microscopy is good to put diagnosis, and by years, I said, no, I have to have immunofluorescence obligatory, especially in some setting, such as if we have a patient with hematuria, I have to do immunofluorescence for this patient. By time I started to believe that in a good number of cases, I have to have EM, electron microscopy as well. In the past, we thought that we need a special preparation of tissue to do electron microscopy. But I think Dr. Fatma, with one core, if she have sufficient glomeruli in the conventional preservation, she can do EM, and she has many photographs which shows that EM can be done in a routine way with the ordinary preservation of kidney tissue. Yeah.
Very good, very good. Thank you so much, Dr. Sabri. I think we are going to move to the next presentation, and maybe Dr. Nagy can present Ahmed Rafat.
Ahmed Rafat is a lecturer of nephrology in our department in Mansoura. He is very intelligent guy. Ahmed has been working hard actually in the field of dialysis and keeping the water treatment system at the best way, and he is interested in many aspects in nephrology. I think he will now present a case about MPGN. Ahmed, can you start?
Yes, okay.
Are you okay, Ahmed?
ايوه يا دكتور، هو الشير بدأ؟
Not yet. In the middle of the
we can
screen,
see
there is
your
a green
screen.
button called share screen. You need to press on it.
I did it, but no sharing.
Okay, so click on share
You're
screen
already
again.
sharing. Just open the PowerPoint presentation. We are seeing your just computer with the folder, the anti-GBM folder.
Okay,
Share
I
your
can
screen.
start. Okay,
We cannot
Yes,
see
please.
your PowerPoint presentation.
you see it?
No.
No.
Is it open already?
Yes.
Share it. I mean, close the share and
Yeah.
just share again.
Yes.
Okay.
You haven't shared any screen before, Ahmed? We cannot
I
see
try
your...
I try to share it again.
So please, Dr. Ahmed, click on the green button in the middle, like share screen again.
Okay.
Okay, when you click it, you will see multiple screens. Just choose the one it
I did it, Mamdouh. I did as you say, but
yeah, just click on share screen again and choose the one on the yes. Now you are
Very good, very good. Go ahead, please.
now I can
Go
start.
ahead, please.
Yes.
Okay. Our case is a female patient, 40 years old, history of diabetes 2 years ago on glimepiride, history of hypertension 2 years ago on bisoprolol, and history of chronic abuse of analgesic, diclofenac, ibuprofen due to headache. Patient complained of anuria, persistent vomiting, and bilateral edema lower limb 3 days ago. And she did some investigation. The creatinine was 13 milligram per deciliter, and there was anemia with normal platelet and white blood cells. And the EPG showed metabolic acidosis and hyperkalemia. And she referred to our department and started hemodialysis daily. And on clinical examination, there is a very high blood pressure and raised blood sugar with normal respiratory rate and oxygen saturation and normal body temperature, and chest examination was free. Abdominal ultrasound was normal apart from grade 2 echogenicity, and fundus exam show hypertensive retinopathy. Serology and virology were negative. We did and double strand ANCA CB and HCV and HB and HIV antibody was negative. After 7 days from the admission, kidney biopsy was done, 10 glomeruli per section. It shows that there is a mesangial hypercellularity of the basement membrane, so it is an MPG pattern, and show a cellular crescent, 5 cellular crescent from 10 glomeruli, and acute tubular injury. So it is a case of MPGN with crescent. We asked her for immunofluorescence and started the management as a crescental glomerulonephritis by pulse steroid 0.5 gram per day for 5 days and pulse cyclophosphamide every 2 weeks. After starting the immunosuppression, urine output improved, average 2 liters, and the creatinine decreased to 2.4 milligram per deciliter, and the patient stopped hemodialysis. And we do a urine exam. It shows neither proteinuria nor hematuria. It is the first urine sample. Immunofluorescence show linear IgG deposit in capillary wall with thin linear C3 and negative IgM and IgA. So we continue the management as it is a case of anti-GBM glomerulonephritis, but we did serum anti-GBM antibody and it was negative. To summarize, a female patient diabetic hypertensive presented clinically by RPGN, serology virology negative, light microscope MPGN with cellular crescent, immunofluorescence linear IgG in capillary wall and scanty C3 and negative IgM IgA. Last update in days ago, creatinine 1.7 milligram per deciliter, urine blood 2 and RBCs from 40 to 50, hemoglobin 9.1, serum blood electrophoresis was negative, and electron microscope was requested and still waiting the result. So we have 3 questions. Is it an anti-GBM glomerulonephritis or there is another diagnosis? And if it is anti-GBM, so we can start plasma varices or not? And is it common to see anti-GBM glomerulonephritis with MPGN pattern? Thank you.
Thank you so much, Ahmed, for the nice presentation. Let's open the case for discussion. And I think I will start by Dr. Peter Sawaya. What do you think about this case, Peter?
Again, I mean, it's so impressive how she responded. I mean, this is a remarkable response. I wish all our patients will respond like that. I really question the diagnosis of anti-GBM very, very strongly. I mean, linear deposits, and probably Dr. Fatma can comment. Sometimes, you know, and you know, Amr, we published ourselves a case of fibrillary GN that was masquerading as a linear deposit. When you have those fine granules, fine deposits that are stacked next to each other, one after the other, it may give you the feel that it is linear, but really, actually, it is. They call them short band. They call them short band or some kind of that description. So that's the only evidence. That's the only evidence we have that this is anti-GBM. And so I really would like to see the immunofluorescence or send it to Dr. Fatma to look at it carefully with high resolution and see if it is truly linear or not. And even if it is anti-GBM, the antibody is negative. What are we going to do plasma exchange for? I mean, it's already gone. And the patient, you cannot dream of a response like this, particularly with anti-GBM. I mean, they don't respond. I mean, in fact, sometimes we don't treat when creatinine is above 6. And the fact that this one was creatinine 13, so clearly is unrelated to anti-GBM. That's what I feel. What type of MPGN? Will be interesting to see what the studies that are pending now when they come back.
Thank you so much. Ahmed, can you tell us again, please? So this case of MPGN was 50% circular cells, right? Is there any tubular interstitial disease, any glomerulosclerosis, tubular atrophy, interstitial fibrosis?
Mild interstitial fibrosis and acute tubular atrophy and no glomerulosclerosis.
Injury.
What about the blood vessels? Do you have any blood vessels, biopsy? Is there any evidence of vasculitis or anything in the main blood vessels?
No, blood vessel free. Free, Dr. Amr. No abnormalities in blood vessel.
Thank you. Dr. Ala, go ahead, please.
I think I add my voice to Professor Peter. You know, if this is a case of anti-GBM, there is some few case reports of anti-GBM actually with negative antibodies. You know, but in such cases without any respiratory symptoms, with drop of serum creatinine to 1.7, just on steroid and cyclophosphamide, I don't think plasmapheresis will add benefits to the treatment. I think this is a case of MGN with crescentic transformation more than a case of anti-GBM.
Agree. I think, as you said and Peter said, it's just a pseudo-linear deposition, but we need immune fluorescence and electron microscopy. What do you think, Dr. Fatma?
There should be electron microscopic study, and I asked for electron microscope, but it is somewhat delayed to be sure that these are linear or finely granular. There should be electron microscopic study before considering it as an anti-GBM.
Right. And by the way, the case that we published, me and Peter, several years ago, actually we started treating the patient as anti-GBM case with plasma exchange till we get 5-6 days later the result of the electron microscopy, and it was very clear that it was February GM. So sometimes we just miss the diagnosis based on only the light microscopy. But anyway, it's a case of MPGN with 50% circular cells. Is she still on any steroids or cyclophosphamide now, Ahmed?
The last dose of cyclophosphamide was yesterday, and she was on solubrid in prednisolone 20 milligram per day.
So how many doses of cyclophosphamide is she getting monthly?
Half gram every 2 weeks for 6 doses.
Oh, okay. And 20 milligram of prednisone.
Can I have a comment, please?
Just go ahead, Dr. Saab.
Yeah, it is very interesting case. And of course, we are waiting with curiosity the result of EM. But having positive immunofluorescence linear deposits and negative serum, possibly the case was diagnosed too early. So antibodies formed are absorbed by the kidney, and no sufficient antibody to be detected in the serum. A phenomenon like when we have in kidney transplant and antibody-mediated rejection, you may find CD4 deposits in the kidney, and the serum is negative. So I think possibly it is an early case, diagnosed early. We detected the linear deposit, but of course there is possibility of this fine granular deposits, and it is pseudo linear. But EM will answer this. But still, it can be linear, as Dr. Ala said, and serum is negative since the case is diagnosed early. All formed antibodies are absorbed in this stage. If we biopsy it, if we do, if the patient was not treated and we did serum later on, it can be positive. The good response of this case could be explained by two things. Number one, she reported presence of acute tubular injury. Acute, so the creatinine is high by this glomerular lesion plus tubular injury. If tubular injury recovered, this can cause a significant drop in serum creatinine. We see this, for example, in the case of minimal change nephritis presenting with high creatinine due to acute tubular injury. When the tubule recover, we get normal creatinine. For possibly the case improved due to improvement of acute tubular injury, beside the presence of cellular crescent and early induction by cyclophosphamide can give good response like that. I think if the case was diagnosed late and this high creatinine is mainly by this MPGN, we will not have good response like that we observed in this case. So early diagnosis combined lesion can explain unexpected recovery.
No question, Dr. Rafat. That is absolutely what has happened in it. And as Dr. Sabri said, the negative anti-GBM, this can be a finicky test. Now, sometimes, you know, you have to do it correctly, and it depends on what method you are using to measure the antibodies. So you can be a negative even if it is in the blood. So that is known. But then to go back and circle back to your question at the end of the slides, how could that MPGN be with anti-GBM? Does anti-GBM present as a form of MPGN? And I think that is very rare. I mean, you know, what we see is an aggressive focal segmental glomerulonephritis that is, you know, not very unusual even to be a diffuse glomerulonephritis. So that's why putting it all together, and plus knowing MPGN, as I'm going to be talking in a second, there are those forms that they cause those fine granular fibrillary or whatever, you know, the small deposits that can masquerade, because all your money now is in this linear deposit. That's all what we are putting our our thoughts on the cause of this case. So that's why putting it all together. But yes, could be. I mean, again, as you said, if it was, let's say, a segmental focal glomerulonephritis and anti-GBM, and again, creatinine of 13. And in fact, this is a good point to make, doctor, is that sometimes, as we said, look at the textbook. They say if creatinine above 5.6, forget about it. But again, if the 5.6 is not because of the aggressive GN and the crescents, but rather for ATN, which they can have ATN, they can be sick, they can be vomiting, they're already compromising their glomerular perfusion, so they can get ATN. Plus, this woman, she may be taking non-NSAID and stuff like that. So that is a very, very valid point that you made there.
Very good, very good. Gaia, do you want to comment on this case? Would you continue with the cyclophosphamide and small dose of prednisone, or you stop that gradually?
Yeah, I think it would actually be very helpful to get the electron microscopy. I know it's delayed. I think until you have that back, I would continue the regimen you're doing since it's working, and that probably won't take that long. And then, you know, it seems everybody agrees that the chance that there are going to be some kind of deposits or evidence of antibody antigen complexes there will be on the higher side. So I think if it confirms our suspicion, then you can sort of switch your management to more of like an immune complex GN, and then consider maybe a maintenance therapy like Cellceptor Imuran. You know, it's a good point about the tubular injury being a factor there too. So that can also dictate how long you want to keep the person on therapy. But since they had such severe inflammation too with the MPGN, I probably would do a maintenance regimen. But I would wait for the EM before you decide what you're going to do.
Another, I think, interesting thing in this case is the urine analysis at the time of recovery was negative for protein and blood. I was shrugging. I said, how could that be with that such a severe disease? But that, again, probably a point for ATN. And you know, when ATN recovers, they flood. The urine can be very dilute, very, very, you know, water-like, and it may have flushed all the cells and things that you didn't see it. But then when she returned to the clinic now with a more concentrated urine, here the proteins start showing and more visibly. I think I'm just theorizing, or it was not with the urine analysis right at the recovery. Just I want to make that point.
Very good, very good. I think it's a, you know, a good example that we cannot only depend on the light microscopy, clinical presentation, full picture, response to treatment, and also immune fluorescence, and, you know, full exam with electron microscopy would be very helpful in such cases. Thank you so much, Ahmed, for this nice presentation. We are going to move to Dr. Peter Sawaya's presentation, MPGN pathogenesis and new classification. And Peter is the Associate Chief of the Nephrology Division in our university at University of Kentucky. He is the Deputy Editor in the Clinical Nephrology Journal. He's one of the best American teacher and best doctor for several years. He's altruistic, selfless person, very humble, very knowledgeable. I consider him as one of my best friends and mentor. I'm very happy that he is contributing with us in this course, and I'm very sure that everyone will enjoy his talk. Peter,
thank you, Amr. Thank you, Amr Habibi. Listen, first I want to thank Mansoura faculty and trainees. Really, I'm very impressed with this conference, and I mean, we always have like sistership, and we say we are having, you know, some kind of collaboration with other institutions, but I've never seen something like this. I've never seen such an enthusiasm, and it speaks for itself. We are doing it from our heart. We are really, really interested on improving both sides and learning from each other. And that is showing very, very, very clearly. And I cannot thank you, Amr, for yourself, because I know it's all single-handed. You did all that on your own, and I know how much, not political, how much bureaucracy you have to go through to get this off the ground. And I thank you. And also would like to thank Mansoura for those trainees based on that program that came to us. Mamdouh is one of them. I mean, they are incredible. They are head and shoulder above many of our trainees, and And I'm so happy with this. Again, they added depth. I mean, Mamdouh attended every single conference we had over the year in our division. And you know, we have 6, 7 every week. And he was there. And I know if I'm speaking and I know Mamdouh is there, I better be on my toes, because really he adds depth to our conferences. And lastly, I would like to thank Mansoura too for giving us Amr. Amr El-Husseini was really, I mean, he's a dear friend of mine now, but he has really propelled us in many areas. And I thank you for producing him, but don't you dare and steer him back, okay? You're not, nobody's going to steal him back from us. I'm telling you, just jokingly saying that. What I'm going to talk today is about MPGN a little bit, and I'm fascinated with the look of it. I mean, I was always fascinated with how it looks, and then when we start understanding its pathogenesis, I became even more fascinated about, and that's what I want to share with you, more than treatment, because again, the treatment is such a wide differential, but I will discuss some part of it. And in addition thing is, I think the old classification, we shouldn't call them old or new, you know, it's just a different classification. The old one is still, you've seen, like, it's called electron microscopic classification, you know, that kind, just the look of it by electron microscopy. And I think that can remain as a classification, as a pathological, specifically electron microscopy classification. But for clinical purposes, for what to do for the patient, I think this new classification is far more informative and helpful. I have no disclosure. Okay, so my objective, identify MPGN pattern of injury, the one that I like it. It's like I like to have on it, like on my wall, like a nice pictures. Recognize the pathogenesis of GBM duplication. Recognize that it is a pattern of injury, not a disease. List the classification of MPGN based on now immunofluorescence, not electron microscopy, and list the common causes of MPGN. Finally, I'm going to review just few therapy on common one that we see, hepatitis C for us, probably for you would be schistosomiasis, you know, proliferative GN with monoclonal immune deposits, and C3 glomerulonephropathy or glomerulonephritis. So this is the look of it. This is the picture that I like. I still remember the first lecture, I think was Glassop, when I was a fellow giving us lectures. I mean, it fills the slides. When you look at the glomerulus of MPGN, you'll say, wow. I mean, it is like a full moon, like a full moon. In fact, there is a Mansoura over the Nile, the picture of a moon. I mean, that's very impressive, by the way. I'm sure you've seen many of it. That's how it looks. A huge, big glomerulus that is filling the field. So that is one thing that will strike you. And then, of course, a lot of cell proliferation. And it's both usually. It can be mesangial often, but also endocapillary, where you plug the whole glomerular capillaries are full with cells. Everywhere you look is cell. And this mesangial proliferation with the cellularity and the thickness of the basement membrane, that I'm going to refer to it in a second with the next slide, this splitting of the basement membrane, and not splitting, shame on me, duplication of the basement membrane that you will see will give it this lobular. It's like they are all like islands. You can see them, each glomerulus becoming very like an island by itself. This lobulation, again, very accentuated. Many glomerular nephritis can do that sometimes, but not in such a prominent fashion that you have this lobulation of the glomeruli. So just the look of it, the pathologists say, oh, it looks like MPGN, just looking at it. Now, if it dwells a little bit on this right picture that I had, and we get a little closer, So you'll see again mesangial proliferation right there. See, there's not where the capillary are. The capillary are back there. But also you see the endocapillary proliferation. So truly diffuse pan-proliferative disorder. And then you get the double contour or the tram track that you will see with the basement membrane. And you see it, they become thin on one hand here, and this is thin, the second one. And here again, here's one. And that's why they call them tram track, like a train. And you'll see it here, duplication in all of them. Now, and also, I mean, if you be careful, again, you can see this eosinophilic material right there and lining on the inside of the capillary. You can see the capillary here, beautiful, and here again. So you have these eosinophilic deposits that are, you know, again, usually pathologists, a good one, they will comment that likely to be subendothelial deposit, but obviously we look for the EM and the immunofluorescence to confirm that these are immune globulin with subendothelial deposits. Now the splitting of the basement membrane, again, I'm saying it again because I'm an old, look at my gray hair. That's what we used to call it, splitting. Actually, it is not a splitting, it's de novo making a second layer of glomerular basement membrane. And I will illustrate a little bit in a schematic way. If you look at it on this side here, this is the MPGN, the type 1 in EM that we call it type 1, that you'll have. A better term for it, I really like this term, is mesangiocapillary. And I will show you why this is a better term to me. It makes more sense, mesangiocapillary. Because first, when you have those deposits that I just showed you that are subendothelial, those black stuff right here, and the orange things is the endothelium. So they are right under the endothelium, and the purple thing is the basement membrane itself. So they are right subendothelial deposits. So to clear them, you know, those mesangial cells, they are big, they are a machinery. They have all kinds of lysosomes and all kinds of things to actually works like a vacuum. They come in and they resorb those deposits. To get to them, they have to migrate. So they send those interposed mesangial cell processes. Now, if you go back to Dr. Fatma's pictures, you will see mesangial cells, they stop right here. They don't send those cytoplasmic, not podocyte, cytoplasmic extensions, that they are going up there to really try to resorb these deposits and clear them up. And that's why I like the term mesangiocapillary glomerulonephritis. It makes sense. And as you know, the mesangial cells are really the major factory of the glomerular basement itself. So now that they are migrating to the capillary loop, they start making those de novo basement membrane. And that's why you have this classical double contour or tram track that you will see here. And here is the electron microscopy. You can see here's the basement membrane. Here's the urinary space, podocytes here endothelial cells. Here's the deposits under the endothelial cells. Here's capillary loop. And here you can see the mesangial just coming in, creeping up, and again, forming this de novo. This right line here is a de novo pseudo, if you want to call it, the basement membrane. This is the original one. And here, this one flimsy, that will give us the double control. So classical of MPGN. Now, type 2 in AM, again, let's specify. So when we say now type 1, type 2, type 3, I'd like to always follow it so we won't get confused now. Just type 2 by EM, you know, so I know what you're talking about. So that's the dense deposit disease, a much better term than saying type 2. This is a dense deposit disease, very distinctive. You saw beautiful pictures from Dr. Fatma, the sausage-like, and they are intramembranous. They are right inside intermembranous, in the glomerular basement membrane, not subepithelial, not subepithelial, or not subendothelial. And here you have the picture again that you just saw. Very unique disease with a very unique pathogenesis. So why is this happening? What is this happening? You know, you need chronicity. You need antigen stimulation for long period of time to get those subendothelial complex deposition and then migrate those mesangial cells and try to lose them up. So there is a chronic antigen exposure. Now, when it is infections, I mean, ultimate for us chronic here in the United States, hepatitis C. I mean, you know, antigen, I mean, there are 20 years on them. I don't know how many years they have that antigen floating. And my understanding, you have, you know, again, from Syria, where I'm from, or from you or in Egypt, there are probably different diseases that can cause this chronic antigenemia in the blood of a person. And that will give you chronic, not just you form them and then you form again and you form again. You're just like bits, doses, small doses of antigen antibody that you keep getting to the patient. And then, of course, the filter, the kidney is going to suck them in and they will deposit the subendothelial. You activate its classical pathway of immune complex. So you have both C3 and C4 in this, the infectious type of MPGN type 1, that you will have complement activation, get all kind of chemotactic effects, cytokine growth, capillary wall damage. And that's what give you this very messed up glomerular basement membrane, as disturbed as it can. And of course, later on, we'll have more decrease in GFR. So the new classification that Dr. Fervenza in Mayo in 2012 came about, and it really changed our way of looking at it. And now it's in every textbook, and of course in up-to-date and in any textbook. So we have first a pattern of injury. So please don't call it disease. I don't want to skill MPGN disease. No, it's MPGN pattern of injury. You've got that. And as I said, look at a few of them, trainee who are there that you are learning nephrology now. Just look at it one time and that's it, that you recognize it just by looking at it. So once you have this pattern of injury, you are going to classify it. Is it immune complex mediated? That means both antigen and antibodies are there. They're sitting in the mesangium or on the subendothelial, or only complement. So you have only very intense C3 or C4, but no immunoglobulin. IgG, IgA, IgM, they will be negative or clearly much, much weaker. And I think they define it by two level higher density, intensity of the complement. And then you can't see the no complement mediated and no immune deposits. And here you have it. And I can say a few words about it later, that you don't have these two in it. And finally, you may have immune complexes, but you really don't know where they are coming from. Usually the idiopathic do have immune complexes in it, but you search, you can't find a cause or why this patient has MPGN. Usually it's a kid, the children, young adult, pediatrician, nephrologist, they see it more often than we do, and we call it idiopathic. And frankly, that's before we had this classification. Probably they were misclassified, or we really didn't look carefully enough in those old cases of MPGN. So the first one, immune complex mediated MPGN, infection. That's the number one. For us, United States, Hep C comes right up there. I mean, I don't know how common it is in Egypt, but I would presume, I mean, we did a lot of blood transfusion in the 80s and 90s. I mean, and now we are paying the price. I don't know when we started in the early 90s to check for the hepatitis C. So anyhow, so that's for us is the big leaders. Now, hepatitis B can do it, but for some reason, B give you more membranous, which I think that would be a topic for the part 2 of this series that we may discuss membranous. But more common you see was hepatitis B, which is very more common in Syria and in Egypt, I presume, that you will have than MPGN. And again, you would wonder why. I wonder if it is more acute kind of B or less insidious, or you get sicker, I mean, or cirrhotic or what have you, faster with B than when we see more indolent. And again, this process of slow antigenemia is important to have this pattern of injury. Bacterial SBE, I mean, subbacterial endocarditis, it can be missed, guys. I mean, we know it from all time, even rheumatic fever that we used to have in Syria. I mean, you have it, you can go for years without, really not, and patient feel lousy, little fever, and you don't nail it until you do those blood cultures. And so you can get their shunt nephropathy, those that they have shunt between the for hydrocephalus, that they would put it with atrium and ventricular, intravascular, intra-abdominal abscesses. They can be insidious, again, chronic infection, not killing you, yet they are there. So those are the type of chronic infection. I wonder, osteomyelitis may be also over there. It's, again, chronic disease that is very infected. Protozoal, for you guys, schistosomiasis, I highlighted here. Malaria has been mycoplasma and leishmaniasis. If you are in South America, that you'll have leishmaniasis. So these are common. Obviously, this is not a comprehensive list, but the point is, you are going to search for infection. When you see that lesion, it behooves you that you are going, immune complex C3, C4, both low, that you are going to do a blood culture. You are going to check for hepatitis B and C. I don't know if I will check for schistosomiasis here in the United States, but definitely in you are going to check for that. Now, the second, again, complexes of antibody-antigen is autoimmune disease. And here you get lupus. Lupus comes with everything. I always tell the student, whenever they ask you any question, tell them lupus, you are right. And that would be the situation. It can give you MPGN pictures. And obviously, if you have an MPGN picture with SLE, it's going to be class 4 here, diffuse proliferative lupus with membranous lesion. Sjogren, most of the Sjogren that I have seen in my life by far are chronic tubular interstitial disease with distal tubular acidosis. They come to my stone clinic, and that's how I have them. They have a really tough stone disease. I yet to see probably a true immune GN with it. Rheumatoid factor arthritis, also more membranous usually than MPGN with it, but it is listed. And finally, the new kid in the block is monoclonal gammopathy, and this situation of monoclonal or renal significance. Of course, if multiple myeloma is in the background, if lymphoma is in the background, or CLL background, Waldenstrom, rarely, but again, it can cause it. But the toughest one that we deal with is MGRS. The MGRS is a bad disease, and because kind of nobody wants to own it. We know it. We know it's a malignancy. We know it's a clonal proliferation from some kind of cells, and we send it to the oncologist. Oh, no myeloma. I don't have myeloma. It's not my problem. Or a lymphoma. So you have to have an oncologist that is interested or agreeing that MGRS is really malignancy. It's related, just affecting the kidney. Help us. I mean, honestly, I'm not very savvy, at least probably now the younger generation are more savvy with the newer treatment of myeloma and such, that they may treat this disease with or without oncology help. And I would like to heal the audience here. What is your experience in Egypt with this connection? So to make a monoclonal immunoglobulin mediated MPGN, you've got to have all these things. So this is your MPGN pictures. You have the lobulated, big, large glomeruli, and then if you look carefully, the duplication. of the basement membrane. You have a significant IgG, so that's bread and butter of MPGN. And of course, if I put for you C3 here, you see a lot of C3, same pattern, loop pattern. You put kappa, it comes the same thing. So this IgG has kappa in it, the light chain of it is kappa. But look at lambda. I mean, lambda is completely negative. I mean, this is striking. This is striking monoclonality that you have only kappa. So a cell that producing only kappa IgG that is stuck. And hopefully, if you do plasma electrophoresis and IFE on that patient, it will be IgG kappa monoclonal protein. I mean, that's what you see. It corroborates. Now, if you do a SPEP and it will come back IgM monoclonal or IgA monoclonal, you scratch your head. What is this? That doesn't make sense to me. The kidney is stuck with something that is different in the blood. Here where you start thinking harder and figure out what's happening. But when everything fits, you know, the plasma is same in the kidney, then you've got your diagnosis of monoclonal. Here are the deposits that you see. Here's urinary space or Bowman space, if you wish, and here's capillary loop and the deposit. So that will make you exactly type 2 now, if you call it, or second form of a monoclonal GA. So complement, so those are both our complex, you know, antigen antibody. Now you have only complement. It can be C3, more rarely C4, but has been quite described with it. And usually here we have either a mutation in the regulatory protein, you know, H, factor H or factor I. They are not making it. There is a mutation, or they are making a defective one. Or the older the patient gets, usually you see it. These are more, you know, a younger patient. These are older patients. They form autoimmune disease, or they, you know, even myeloma. They can have it. You know, they form antibodies that attacks those factors. Anti-factor H or anti-factor I, and you can send a battery, in fact, you know, to many laboratory. In fact, in UpToDate, I mean, at least in the United States, we have a list of all labs that they do a full complement assessment to see which one, where the problem is, because obviously they can benefit from plasma exchange if they have antibodies. Now, dense deposit disease, it is a C3 glomerular, not nephritis, glomerulopathy. So if both of these, I want to put a title on top of them, I will say C3 glomerulopathy, not glomerulonephritis, because dense deposit disease is a C3 glomerulopathy, and usually with C3 nephritic factor, honestly, only 50% is present that you can measure it. But again, you cannot miss it once you see those EM that I showed you. So it's good to separate it on the side like this. So now when you have non-immunoglobulin, non-complement mediated, and Dr. Fatma mentioned some of those, HES, TTP, but usually I tell you, antiphospholipid and can give you full MPGN looking. Transplant glomerulopathy somewhat. HES, TTP, usually it's a patchy. You see duplication of the basement membrane in a patchy kind of pattern, not this huge glomerulus that is diffusely, but apparently in the healing process of it, you may see it. So these are the other things, you know, bone marrow transplant, sickle cell anemia, and radiation nephritis that give you a picture. And mostly here we are talking not as much proliferation as much as duplication of the basement membrane that you will see. And patient and the pathologist may say, oh, it's little possibly MPGN pattern of injury. So you'll start thinking, oh, it's MPGN, and let's look at for those infection and all those monoclonality. But again, if you have one of these conditions that are obvious, you know, send for antiphospholipid, you would say to yourself, yeah, probably this is related to really HES that I know the patient has a full HES or hemolytic macroangiopathy. So idiopathic, okay, usually, as I said, with immune complex, but no obvious cause. And usually is a young kid. I mean, somebody 15 years old coming in with nephrotic proteinuria, hematuria, hypertension, low complement level. I mean, this guy has nothing, no lupus, no hepatitis, nothing. He's a kid, you know, he's 15 years old. You find nothing in them. And they end up by being in this idiopathic category. So an evaluation of when you have this pattern of injury, always start with, of course, good history and physical exam. You got to look for that infection. You know, have you had a blood transfusion? Have you had, you know, like the case I think we're going to present, you know, the farmer, you know, what's your, you know, exposure to something that can make you, you know, have an infections. For us, IV drug use, I mean, oh gosh, how many cases of IV drugs induced SBE? I mean, you know, and then you'll have a glomerulonephritis. Amr probably have seen a slew on the floor. He does more inpatient than I do, but we have tons of those patients. Again, I don't know how common that is in Egypt. Typically, patients have nephritic and nephrotic. This is one of the pattern of injury that really actually give you both pictures. Nephritic, I mean by that hypertension that Dr. Rafat case showed you, presented around 180 over 100 blood pressure. So we have hypertension, a lot of hematuria, and dysmorphic red cells and red cell casts. So they look nephritic, but tons of protein, and sometimes a really incredible degree of edema, not just proteinuria, 4 or 5 grams, but also the edema that goes with it. And so it's really, you have both pictures, and this is classical for MPGN from all the diseases that can present both ways. Now, of course, lupus, as I said, mention lupus anywhere. You can have class 4 and 5 at the same time. Active urinary sediment and nephrotic range proteinuria, infection, autoimmune. You have to do the workup. I don't want to list here and make you busy slides, but you understand what I mean by autoimmune workup and by infections. Monoclonal poly, you've got to do a seroprotein electrophoresis, IFE, and urine for Benz-Jones protein or immunofluorescence. Again, you like to do IFE, again, to match. Is it, you know, okay, you can see a monoclonal protein, but is it IgG kappa? I mean, and that's only immunofluorescence electrophoresis can do that. So you have to do the immunofluorescence to say, yes, this is IgG kappa, not just I have a monoclonal protein that is IgG, you know. Complement levels, as again, you know, most of the C3 or type of the MPGN will be C3 only down, not the classical pathway that you have with the autoimmune immune complex diseases, where both the classical pathways, so C3 and C4, both are down. Rheumatoid factors also, that's again, I don't know how, it's very, very finicky to do cryoglobulin test. You have to be very careful. You have to already warm up a little bit in your hand, or somehow the tube that you're getting the blood. I mean, of course, in Egypt, you don't have much coldness as we do have, because they may precipitate before they get to the lab and they may become negative. So false negative is very, very common in this test. But rheumatoid factors, again, it's a Poor's-Man cryoglobulin because both of them are IgM, and you will have a rheumatoid factor positive in those that have cryoglobulin. And cryoglobulinemia will change the therapy if you have it, and it has a more classification of what to do once you have it. If you have Hep C, I'm going to focus on, I don't know how I'm on time. I'll go fast. Selected causes of treatment. Hep C for us, it's a nightmare again. MGRS, that's monoclonal gammopathy of renal significance without multiple myeloma and lymphoma. Again, sometimes it falls back on my lap. The oncologist said, well, it's not my problem. They don't have those diseases. And C3 glomerulonephritis that is presenting as an MPGN pattern. So the hepatitis C general management, of course, all MPGN, everything's got to do what you got to do. I mean, you know, all glomerulonephritis, blood pressure control, edema control, as Dr. Giara yesterday said, lipids, ACE inhibitors, and ARBs. Those are like a given. They should be mixed in the water the patient is drinking. Now, direct acting antiviral therapy for hepatitis C has changed the treatment for us in hepatitis C. When I was younger, 20 years ago or so, the hepatitis C was a nightmare for us, nightmare. because often they have decreased kidney function. You cannot give ribavirin, and if you give them ribavirin, they will wipe out their white count. Interferon alpha is a nasty drug, guys. I know you've used it. I mean, it is a really nasty drug, all kind of side effects from it. It was absolute nightmare. Now, with those oral agents, my gosh, oh, you're a phenotype. And again, I am not savvy in what to use, which one to use, what genotype you have. I let the hepatologist deal with it, but you got to treat them for me. And if they decide they don't need treatment, I force treatment on them, tell them for the renal purpose, you are going to treat that person. And again, these drugs are very expensive, guys. I don't know how it is in Egypt and how available to you it is, or how common even that disease is. I do not know. But these have changed. And most of the time, the disease is not that severe that needs immunosuppression. You have 1-2 grams of protein, normal creatinine, blood, in the urine, and so you start those treatments and let it heal by itself over time. Now, when the disease is severe, you have crescent, you got treated like crescentic GN, regardless. If they have vasculitis, as I said, with cryoglobulinemia, and vasculitis. I mean, you are going to damage the tissues wherever that is. So in that situation, perhaps rituximab comes up on the list because again they are, produced by B cells and usually with steroids. I mean, again, rituximab, again, for you guys, I'm old enough. It's a new drug still to me. It's a new drug. Cyclophosphamide, that's what we used to use for a long time. But now, if you don't have rituximab, you can use cyclophosphamide when you have those severe cases. Now, when you do a plasma exchange, I think it's a little controversial, and I've seen it in a different ways. Up to date, what I said, and in fact, comprehensive nephrology, they are limiting it to pulmonary hemorrhage and crescentic GN, requiring hemodialysis, which is the classical use of TPE for crescentic GN. I don't know. I mean, if I know that somebody has a lot of cryoglobulin floating in their blood, and I get that pictures that Fatma showed you, Dr. Fatma, that you have those, I mean, the capillaries are literally plugged with those viscous cryoglobulin. I don't know. I feel like, yes, get them out of the blood. I mean, let's see them. So whether it is the amount, and as I said, I mean, they say if you more than 10% cryocrit you have in your blood, go ahead, do plasma exchange. But often the test is false negative, and so if it's false negative, you can have low titer too, correct? Some of them are precipitated and we couldn't measure them, so you can have a low titer. I don't know. I'd like to hear the Dr. Kapok from the Penn what they do in their center. Start antiviral therapy a few months later. If you are going to do immunosuppression, they are recommending that don't start the antiviral, cool off the kidney, because again, it's double whammy side effects, and probably they won't be as effective if you are giving all the immunosuppression. Wait for a month or two and then hit them with the antiviral. That's what they are recommending. I will go treatment of proliferative GN with monoclonal immunoglobulin depositions. And this is, again, you do not have myelomas, but even if you do not have myeloma, that is, 10% plasma cells in your bone marrow, you can tell if there is clonality and what is the source of that clonality. Is it a B cell clonality or a plasma cell clonality? Whether it is from the biopsy tissue of a lymph node or by cytometry of the blood, that you can tell if they are monoclonal. And they're recommending if you will have a monoclonality that is suggests plasma cells, then you will do Velcade. The V here stands for Velcade. Again, you treat them like myeloma. If it is B cell, then you would use rituximab in this situation. Now, if you don't have monoclonality that you can tell, then you would look of what type of molecule you have. IgM, by non-IgM, again, you would presume it is coming from a plasma cells, and you treat them like myeloma. And if it is IgM monoclonality, you presume it is from B cells. And as you know, rituximab is the king to treat B cell proliferation. Now, again, if you do not have even serum electrophoresis is negative. You don't even have a spike, not in the blood and not in the urine, but you know it is in the kidney. What to do with those patients? And here it's really murkier. According to this one, again, from up to date, it depends on how severe the disease. You will decide, and you have to talk to your patient. You can see the graph on your. I think I'm running off time, but this is, I think I saw the questions. In one of the questions, I think, was related to this one, C3GN or deposits. The only thing that I saw was the mycophenolate and prednisone helped. It was a retrospective study. Indeed, 97 patients showed some improvement with this regimen for this particular disease. And it recurs quite a bit in transplant. So my conclusion, new classification help us in the treatment. Chronic antigenemia predisposed to the type of injury. MPGN is an injury and not a disease. Treatment, of course, is vastly dependent on the multitude of cases. A newer antiviral for Hep C are very effective, tolerated, and not need to be adjusted for GFR. And MGRS treatment and C3 is really, our knowledge in treatment is very limited, as I think Dr. Subh mentioned in FSGS, how limited we have the data and poor, there's no trial, there's nothing like that. Thank you very much.
Thank you, Peter. That's a wonderful, remarkable, incredible presentation as usual. And again, back to basics. When I receive a call from a friend of mine or so in Egypt, and he tells me that I have a patient with MPGN. I tell him, what is that? I mean, MPGN is not a disease. We have to dig. We have to dig into history. We have to do a lot of exams and lab, and we have to make sure what is the trigger for that. What is the antigen that trigger the whole process of the mesangio-capillary GN. We cannot do this just based on histopathology picture of lobulated glomeruli or a picture of MPGN. It's just a pattern. We have to find what disease induced that. And of course, the whole treatment is just dictated according to the trigger. If you find the trigger, you will be most likely successful in treating the disease. Dr. Ala Sabri, I think, has a comment.
Thank you very much, Professor Peter, for this very comprehensive presentation about MPGN. I'll just comment on Hep C associated nephropathy. You know that the Hep C is very endemic in Egypt. And actually, since 1996, our godfather in nephrology, Professor Muhammad Sabri, he asked me to do a project about Hep C associated nephropathy. And at the time, there was a very few case reports coming from Japan. I think it was counted on your fingers at the time. Regarding the prevalence, Hep C is a nightmare, as you said, especially here in Egypt. The reported prevalence of Hep C in the past was about ranging from 25 to 30% of the whole population. And this was attributed, as you know, to the mass campaign of anti-schistosomal medication. The old anti-schistosomal medications, the Ambinahar, the IV medication, it was given in a campaign without anesthetic measures. At the time, they used the glass syringe, giving syringe from one patient to another, and this was the reason for the high prevalence of Hep C.
You boil it. I used to boil it with the same coffee that I used to do. Coffee. I boil it with water.
It is the same, actually. It is the same. That's why we had at that time a very high prevalence, and this was reported by our ex-prime health minister, Ismail Salam. I mean, this prevalence. So we did a big study about Hep C associated renal disease. And we published many papers. I think, thanks to Professor Sabh, about 5 or 6 papers about Hep C associated nephropathy. In about 233 patients, we studied the histological characterization of Hep C in such patients. And about 40% of patients were MPGN. Out of these 233 patients, others showed the FSGS, members nephropathy, peripheral glomerulonephritis, but the commonest pathological lesion we found was MPGN. And we selected 50 patients out of them with the highest suspicion of being Hep C associated nephropathy. In such patients, we did cryoglobulin, and as you said, there is a high possibility of false negative test because you should do some precaution to heat the screen, the syringe, to heat the syringe before collection of the serum, to put in the refrigerator very rapidly, to check it 24 hours and 48 hours. And out of our patients, 50% were cryopositive. And as you know, some of Hep C associated nephropathy patients may be cryonegative as well. And in this patient, we did PCR for Hep C, and it was done in Sheffield with the help of Professor Magid Nahas, Professor Magid. And we found PCR in about 50%, I mean PCR positive in paraffin embedded renal tissue where we express the virus by viral retrieval techniques. We found about 50% PCR positive, and we did electron microscopy as well for this patient. And by electron microscopy, we found what we named at the time a viral related particles. These viral related particles have the same or a criteria of a virally induced particle. It was present in the deposit itself. And in the second phase, we treated these patients with interferon and ribavirin. You know, combination therapy was a common therapy in the past. We used the pegylated interferon once weekly for a year time. And the result was really impressive with the decreased proteinuria. As far as I remember, the mean was 4 gram per 24 hours to 1.5 after 1 year, with the disappearance of cryoglobulin, with some improvement of liver function test. I think the picture of Hep C associated nephropathy or Hep C as a whole in Egypt will change with time, thanks for the DAA. And we did another study with my colleague Dr. Ahmad El-Said using DAA for treatment of Hep C associated nephropathy. And if Ahmad is around, he can give us his summary about his project, because I think he remembers the figures better than me. Thank you very much.
Dr. Sabri, if I may ask, for the DAA, how available are they for you in Egypt? And in Egypt, is it like Syria? I mean, once we have a drugs, I mean, the government gives it to everybody. I mean, you know, we once, even for transplant, you know, all cyclosporin, always we've had good. Is that the same system we have in Egypt, or it is very expensive?
Early since about let's say 5 or 7 years, it was so expensive. But thanks to the government, there is a national campaign and national program to eradicate Hep C, which started about 5 to 6 years ago, and it is given freely for this patient. And I think the results are very impressive. And the side effect and the adverse events are quite different from the interferon. You know, with interferon, especially the short-acting interferon, we have many side effects, and with the ribavirin as well, we have many side effects regarding the bone marrow suppression, especially the anemia. So those direct acting antivirus are freely given to Egyptian since about 5 to 6 years. If Ahmed El-Said is around, he would comment on using DEA in his Hep C-associated nephropathy patients. Ahmed is around?
As he's coming, if I may ask, Gaia in the University of Pennsylvania, I'm really curious to know, do you delay the treatment for the virus if you have a severe disease until you start with the immunosuppression? Is this a common practice? And second, when do you do plasma exchange for cryoglobulinemia?
So the first one was, sorry, do you delay treatment until you start the DAA?
Correct. Like you have a severe MPGN,
yeah,
and you are going to start cyclophosphamide or rituximab, and then, you know, do you wait until you start the oral agent, or you start in the
we
same
don't
time?
typically, just because they are so effective. Like most people achieve viral clearance by 3 months. So, so I think that it's honestly so rare for us to see it now because people are detected early now that, you know, guidelines are to screen people, everybody of that age group, and actually even younger, like 20-year-olds. Sorry for my son.
That's wonderful.
Now, because of the opioid epidemic, it's also screening people in like their 20s as well. So it's detected and treated so early now that it's so rare for us to see cryo. I actually see it more, which is funny because this is a rare thing too. I actually see it more in people who have viral clearance, but then get cryo anyway, which is typically a less severe pattern of injury where we're not talking about pheresis and such severe immunosuppression. So it's kind of a weird answer to your question, but that's where we see it nowadays, is in people who have had viral clearance, but still develop cryoglobulinemia. So it's a little bit less concerning to treat them with immunosuppression. But if they have, I think we do adhere essentially to those guidelines where if they're on dialysis, it's more severe where we would consider pheresis. Yeah.
Thank you so much, Gaia. Thank you so much, Peter. Thanks a lot for this very informative discussion. I think we need to move on. We are very, we are a little bit late behind the schedule. So I think the next presentation will be case of MPGN, will be presented by Rabab Arifai. Please go ahead, Rabab.
Thank you, Dr. Amr. Welcome everyone. My case today is about the screen is available.
Yes, go ahead. Just make it in a PowerPoint presentation mode and go ahead.
Is it clear now?
That's fine. Go ahead.
Yes. My case about 55 years old female farmer married with 4 offspring, hypertensive 2 years ago on bisoprolol, history of splenectomy 20 years ago. The patient complaining of edema, both lower limbs.
I'm sorry, we are just seeing the first slide. We are not seeing you moving the slide.
Does it move now?
Not yet.
You need to enlarge the screen.
Okay.
No, I think you have to stop share and share again.
Okay. Is it clear now?
Yes, you're good. Go ahead.
Okay. 55 years old female farmer married with 4 offspring, hypertensive 2 years ago on bisoprolol, history of splenectomy 20 years ago. The patient complaining of edema post lower limbs. Laboratory investigation was done. Serum creatinine was 1.2, urine analysis protein plus 3, other unremarkable. 24-hour urinary protein was 8 grams. ANA was equivocal, anti-double strand was negative, C3, C4 was significantly consumed, rheumatoid factor was negative. Hepatitis B surface antigen, HCV antibody were negative, Bence-Johnson protein negative, plasma protein electrophoresis was normal, schistosomal antigen was positive. So renal biopsy was done, which there were 9 glomeruli per section, diffuse thickening of the basement membrane and mesangial hypercellularity, and by silver stain double contoured appearance of the basement membrane, spike formation and immune deposit. On the other hand, there was 2 glomeruli totally sclerotic and 3 glomeruli show segmental mesangial sclerosis. Regarding tubules, focal tubular atrophy, interstitial fibrosis of 50%, focal chronic inflammatory infiltrate, focal foamy cell infiltration, blood vessels were unremarkable. Immunofluorescence shows diffuse finally granular capillary deposit of IgG, IgA, IgM, and C3. So the diagnosis, MPGN pattern, mostly type 3. The patient received antibilharzia treatment, praziquantal, high-dose steroid, MMF 2 grams per day, ARBs. But unfortunately, 1.5 months later, during follow-up, 24-hour urinary protein was elevated to 9.5 grams per day. Serum creatinine was within range. So what do you think about the management of this case regarding another plan of treatment or another investigation done to reach the diagnosis of the cause of MPGN? Thank you.
Very good. Thank you, Rabab, for your presentation. So the question is, I'm just going to throw this out for discussion. Is it schistosomal associated nephropathy, schistosomal induced nephropathy? Is it just something that, you know, we know that schistosomiasis is not very rare in Egypt, so you can find this in people without GN. When you see it in a patient with GN, how can we make sure that it's, you know, the disease, the MPGN, is induced by schistosomiasis? Peter.
No, don't ask Peter about that. Peter hasn't seen bilharzia.
Used to boil the syringe to treat bilharziasis in Syria.
40 years, my friend, and I don't know even if I saw it in Syria. So I'm really looking forward to the discussion from the group, like we just learned from Hep C, even that you have what is, I don't know how do they see, as Dr. Sabri said, element in the deposits that may be leading towards schistosomiasis? Is there a difference between the type of schistosomiasis? I know there are different types, you know, one that give you more bladder injury and hemorrhage, and one more GN. And so I really, my knowledge in there is zero, and I don't want to be a hypocrite.
Can I comment?
Allow me, Professor Sobh, I think he can give us very informative.
Regarding schistosomal nephropathy, I'll say that number one, to diagnose schistosoma, if we rely on serology, it is not quite good, since false positive results are quite there. So to diagnose schistosoma, we have to do at least rectal mucosal biopsy to detect living ova, schistosoma ova. Without this, you cannot say that patient has active schistosoma. Possibly you may have hepatic periportal fibrosis by ultrasound. You can have splenomegaly and these things, but schistosoma could be dead schistosoma. But so if you are going to talk about schistosoma something, such as schistosomal nephropathy, we have to have a rectal mucosal biopsy, number one, to say we have active schistosoma infection. We know with living bilharzia or schistosoma, there is liberation of antigen from the adult worm in the portal circulation in case of Schistosomal Mansoura. We know that this antigen, it is a gut antigen. The schistosoma feed on RBCs, they digest, and they excrete through vomiting. So by vomiting, the epithelial cells of the intestine are liberated and are there in the circulation, and this is the antigen. To cause disease, there should be portosystemic collateral, so that this antigen coming from the portal circulation will escape the liver Kupffer cells and will go to the systemic circulation, where it will act as antigen, antibody, then immune complex, which will be trapped in the kidney. So you need to say this MPGN is schistosoma, and this we did in our publication. We did a rectal mucosal biopsy, and to say active schistosoma, then kidney biopsy were examined for schistosoma-specific antigen and antibody to say this. Otherwise, this MPGN could be an idiopathic or caused by any reasons, since, as we know, MPGN is its prevalence is higher among Egypt and third world countries than Western countries due to other infection. So we may say this MPGN, but to say it is schistosoma nephropathy, you have to have documentation of active schistosoma, number one, and number two, to detect the schistosoma specific antigen among the immune complex deposited in the kidney. So this is the case of MPGN pattern of something. Schistosoma, is it one possibility? It could be, but we have to find two things. Number one, living all over in rectal mucosal biopsy, and schistosoma specific antigen or antibody in the deposits. If we don't do this, I will consider it as conventional or ordinary case of MPG pattern disease. This is my stage one response.
Again, to be educated about schistosomiasis, do you have a panel like what we have with Hep C? For example, if it's the antigen positive, okay, it could be a dead bilharzia, but if it's antigen positive, do you have also a panel of antibodies to it, or like what kind of serology do you order on those folks that are living now, in Egypt?
Okay, to me, treatment wise in Hep C, as Dr. Ala said, it is easier than in schistosoma, since in hepatitis C, when we treated patient and we eradicated the virus, the patient responded better. We have publication regarding schistosoma nephropathy, and we reported on eradication of parasite if it is followed by a significant response. We found no significant response. You eradicate the virus, the parasite, as the disease persists. So far, it is established disease. Even we did a model in hamster. We infected hamster by Cercaria, and we induced disease, and we reported on this in nephron, and we actually eradicated the parasite, and we confirmed this by doing a laparotomy, and we explored the liver and the portal circulation, and we documented a complete cure of schistosoma, but the infection, the disease was progressive. So we concluded that in schistosoma nephropathy, unfortunately, even if you eradicate the virus, the parasite, when the disease is established as MPGN, it persists. To diagnose on clinical ground, it is no more than suspicion. You have liver and spleen, you have splenomegaly, you have a document of portal hypertension and collateral, and you have active schistosoma. So you will say, most probably it is schistosoma. But to say, to be 100%, you have to do the specificity study of the antigen and antibody, which is not done in routine practice.
Do they have systemic symptoms? Do they have like they are chronically infected, low-grade fevers, or just, you know, the consequence?
Okay. Usually, number one, we try to compare between histology of MPGN in schistosomal specific, and I say cases in which we documented presence of schistosomal specific antigen and antibody MPGN. When we compared them with idiopathic type or MPGN of any other cause, there was no histologic significant finding, which we say if you find this, you say it is schistosoma. It is only documentation of specific antigen and antibody. Regarding fever and this thing, usually we have the patient with hepatosplenomegaly, and we have collaterals, and we find the egg in rectal mucosal, living egg in rectal mucosal biopsy. So this is scenario, but he presented as any nephrotic syndrome, as any proteinuria. The specificity comes when you do a specific. No fever like any nephrotic patient. Yeah, this is the point.
Thank you, thank you.
Dr. Ala, I think has a very quick comment.
Yes, thank you, Professor Sobh, for this very comprehensive talk about schistosomal nephropathy. I just want to add 2 comments. There is a histological classification of schistosomal nephropathy done by the AFRAN, the African Renal Association Society for Nephrology, and the MPGN. It consists of 6 histopathological changes, and the MPGN came as class 3. Second, in cases of schistosomal nephropathy, we should investigate the patient for co-infection, especially for Hep C and for Salmonella as well. Thank you very much, Professor Sobh.
Thank you, Dr. Ala.
Yeah.
Sorry, Rab, we are not very helpful in this case. It's very complicated, but don't only rely upon the positive schistosomiasis. In this case, try to dig more and see if there is any other trigger for this immune complex mediated disease. I think we are going to move to the other pathology, which is IgA nephropathy, and we have Rehab Sayed. She is going to present this case. Go ahead, Rehab. Rehab, are you with us?
Assalamu alaikum. Yes, I am with you.
Just share your screen, please, and go ahead and
Okay.
present your case.
Okay. Is it clear?
Yes, please just make it in a PowerPoint presentation mode.
Yeah. Assalamu alaikum. Welcome and good evening, everyone. Today, I'll present a case of IgA nephropathy. Our case is 22 years old male, single, from Mahalla, presented with bilateral puffy eyelid and grade 3 edema. The story
Rehab, I'm sorry, we're still seeing your first slide.
Okay.
Stop share and put your presentation in PowerPoint presentation mode with a slideshow.
Now you can see it, screen?
It's coming.
No?
No, it's not. Sorry.
Okay.
So you can click on the share screen, Dr. Rahab, and then it shows the box at the upper left corner.
The box? What?
Yeah, just click share screen again, the green button.
Share screen, yes.
Okay,
Yes.
so can you try to start the PowerPoint, like start the slide?
Yes.
Okay.
Start now. Is it clear?
No, that's fine. Just keep going. Make it very precise. We know that it's an act of IgE nephropathy. Just tell us what's particular about your case.
Yeah, you can stop the presentation mode and just move between the slides.
Okay.
So just click escape.
You can see that now?
Okay.
Yeah,
yes,
go ahead,
good,
please.
Good.
Yes. 20 years old male single from Mahalla presented with bilateral buffy iris grade 3 edema. The story started since 2018 with operative repair of anal fistula in January 2018 and an appendectomy later on in December 2018 at Cairo Insurance Hospital. In February 2019, he complained of right upper quadrant pain and bloody diarrhea. Investigation and colonoscopic examination done showing Crohn's disease. So the patient diagnosed to have inflammatory bowel disease in form of Crohn's disease. And the patient treated with 3 grams per day of 5-aminosalicylic acid and 9 milligrams per day of budesonide. At the time, the urine analysis and creatinine were normal. 6 months later, the patient experienced another exacerbation of his GIT symptoms. On examination, his blood pressure was 1,220/75 millimeter mercury. Laboratory tests results show normal blood urine nitrogen and creatinine, although urine analysis revealed mild proteinuria. But unfortunately, the patient didn't have any nephrological consultation at the time, and he was treated as another exacerbation of Crohn's disease with another course of 5-aminosalicylic acid and budesonide. On September 2021, the patient experienced facial buffness and edema in his lower extremities. On examination, blood pressure was 140/96 millimeter mercury. Proteinuria was 3+ by dipstick. Microscopic hematuria also was detected. His renal function at the time was deteriorated and the creatinine was 3.9 milligrams per deciliter. He was referred to nephrology clinic and admitted for evaluation. 24-hour renal study revealed the presence of nephrotic range proteinuria, 3.5 grams per day. Further testing in the form of serology and virology were done and all were negative. Renal ultrasound showing bilateral normal both kidney. Renal biopsy was taken and showing 10 out of 15 glomeruli with cellular crescent, mild tubular and interstitial atrophy, with diffuse inflammation, interstitial inflammatory infiltration. Immunofluorescence showing diffuse immunoglobulin A deposit. So the diagnosis was subsequently rapidly progressive IgA nephropathy associated with Crohn's disease. The patient was treated with pulse steroid and pulse cyclophosphamide. Serum creatinine dropped to 2.5 milligrams per deciliter, and the proteinuria decreased to +2 by dipstick. Spot urine ratio decreased to 1.5 milligrams per gram 3 weeks later. After 3 months, during follow-up visits, the patient was maintained on steroids 30 milligrams per day and aspirin 100 milligrams per day. And this time, his serum creatinine was dropped to 1.9 milligrams per deciliter, and spot urine protein creatinine ratio was decreased to 0.9 milligrams per gram. So the patient is improving. Thank you.
Thank you so much for your presentation, and let's open the case for discussion. Gaia, if you are with us, what do you think about this case?
I like the case. I mean, it's a great case, great presentation. But one nice thing is we've seen this association between IBD and IgA nephropathy. It's described a lot, but it's been hard to like get a comprehensive, case series together because it's such a heterogeneous disease. Interestingly, budesonide was just approved here for treatment of IgA nephropathy, like within the last 6 months. So, clearly this person didn't respond. I think the management that the patient got was great with the cyclophosphamide, but I don't think budesonide was like a terrible way to start, even though it was not intentional. Are you planning to keep the patient on such high prednisone now that they've gotten cyclophosphamide?
No, of course, we will withdraw steroid within a few months. He is still now 4 months. We have to another month, and we will withdraw through this.
Okay, great.
I agree with Gaia. I think budesonide, which is Nefecon, that has been approved, FDA approved a couple months ago. Even we don't have published the data yet. They just presented their study, the Nefegard study, in the last ISN meeting, and it showed safety and efficacy in treating IgA nephropathy patients for a year. We don't have long-term study, and we don't have even a single publication. But again, the thing is here, this patient has Crohn's disease, and Crohn's disease, it's an ulcerative, disease, and it's IBD. And what happened is you can just release more IgA from the terminal part of the ileum, and this IgA goes to the systemic circulation and induce the disease cells. So the fantastic thing and the interesting thing about budesonide, which is locally acting steroid that is less than 10% systemically absorbed, it works locally on the terminal part of the ileum, the site of the release of the immunoglobulin A. So I think it would be very helpful. I don't know if it is available in Egypt or not, but it would be very helpful to control both the disease, the Crohn's and also the IgA nephropathy. The other thing, as Gaia said, don't give a lot of steroid. We know from previous RCT, especially the testing trial and stop IgA nephropathy trial, that steroid might be a little bit effective in IgA nephropathy. However, it's toxic. It's not safe. So quick taper, I think, would be safer. Don't induce harm. Peter, what do you think?
Yeah, but this is a different beast. Again, when you get crescentic GN with IgA, you treat it as crescentic GN. And in fact, you forget all about IgA, whatever it is. You got to be aggressive, at least at the beginning. And now, so I see what they done is very nice. And that's what should be done for any crescentic GN and particularly even an IgA. But the maintenance phase, that's very curious. And I was wondering, I saw that the dose that they were using for the local prednisone, budesonide, was like 9 milligram. I forgot, what is it? You had the study, Amr. How much were you giving to your patient when we had them in the study?
Very similar, 6 milligram in the morning and 3 at the evening. I think it's BID treatment. So I think it's very similar dosing.
And
the approved dose of budesonide for IgA is 16 milligrams, but 8 milligrams also showed efficacy.
Right. So the phase 2B study, they studied 8 versus 16. And it seems 16 milligram might be more effective, but the side effects and the tolerability of 8 milligram was better.
Dr. Amr, I have a question to Gaia, Professor Peter, and you, and all the audience. What about other measures to treat IgA nephropathy? I mean hydroxychloroquine or tonsillectomy, especially they are tested in special population, tonsillectomy in Japanese patient and hydroxychloroquine in a Chinese patient. Do you have any experience? Would you advise to test it in another population?
So the studies that exist, oh, sorry, go ahead.
No, go ahead, Gaia.
The studies that exist with those drugs are typically comparing them to RAS blockade. So, I mean, we will offer them sometimes that we don't think they do much harm, but mostly the patients that I put on hydroxychloroquine and fish oil are people that I'm not giving immunosuppression to, just because in trials where they've looked at them, or smaller studies where they've looked at them with immunosuppression, they don't give extra benefit. So for example, I have a young woman who is trying to get pregnant and she has pretty active IgA nephropathy. So she can't be on really anything. So she's on hydroxychloroquine and fish oil. So, so that's sort of the context in which I will use it, or maybe add it to RAS blockade in people that are not getting immunosuppression. CellCept, is also shown in Asian populations and doesn't really have good quality evidence in other races. We still will use it sometimes in people who we feel need immunosuppression, but are intolerant of steroids or have not, had good experiences in the past with steroids, with some mixed effects. I think here azathioprine is a nice choice because, again, it's like also treating the Crohn's disease. We try to get our patients into trials when we can. Somebody put in the chat about rituximab, which I think is a really good thing to bring up. With galactose deficient IgA, which may or may not, it has a good association with IgA nephropathy. There's some people think that rituximab may select for the galactose deficient IgA, so it's sort of mixed whether you should use it or not. In some cases where you have also vasculitis, people will recommend it. So there's a trial now that's looking at atacicept, which works within that pathway, but it's blocking BAFF, which is B cell activating factor, and APRIL, which is another proliferation-inducing ligand for B cells, with the thought that that might be more effective without any adverse effects.
Thanks, Guy. I just, yesterday, I have a chance to review this article that was published in the Kidney 360 journal. And it was a retrospective study for 20 years. They compared people who came in with IgA nephropathy with aggressive IgE, like this case with crescent or RBGN or rising creatinine, significant proteinuria, to another, control group of patient who has quiescent disease. And of course, for the patient who presented with aggressive disease, they received cyclophosphamide, a lot of glucocorticoid, and they said both groups, the quiescent group and the aggressive group, they have the same outcome at 1 year. So they said in general that maybe treating aggressive disease with aggressive immunosuppressive medication might be helpful. Again, this is not RCT or controlled study, but still, as Peter said, in aggressive disease, it might be different. Of course, we know that in mild disease with proteinuria, 1 gram or 2 grams, with normal creatinine, immunosuppression therapy might not be a very good option, but in severe cases, it does.
Can I give a comment?
Yes, please.
This case, initial presentation was too aggressive with crescentic glomerulonephritis. I think this made the decision to treat easy by giving this pulse treatment, including cyclophosphamide. The challenge is maintenance treatment. Possibly we treated or we controlled the crescent and the activity went down. Then how to tailor immune suppression later on? Possibly it is no more active, and we are dealing with the residual functioning tissue and some scar or fibrosis after treating these crescent. So how to judge the activity so that we can barrel by immunosuppressive treatment, i.e., if the 1.9 creatinine is only due to is by the remaining healthy non-inflamed tissue and no more active lesion. Why we give big doses of steroid and immunosuppressive drug? So it is a challenge to tailor immunosuppressive treatment after treating the initial aggressive phase. I think if there is no significant proteinuria, hematuria, we have to go down by the steroid dose and anti-proliferative treatment added to steroid. But how? It is challenging. Another point regarding the classic treatment, which is a local acting steroid, of course, this is a breakthrough in management of IgA nephropathy, which is not available in Egypt, and I think in near future it will not be available. Research-wise, this patient has a Crohn's disease, and we know that the gut microbiota have a pathogenic role in both conditions. So I wonder if we, some people can conduct research regarding a matter such as fecal matter transplantation or in patients like that. You can treat both IgA and Crohn's disease. Possibly, this is a research, of course. But I think this is just this let us say food for thought for us.
Right.
Okay, this is what this is my comment.
Thank you so much, Dr. Saab. I think again that's a very thoughtful discussion. We have Rasha Samir. She's going to precisely walk us through up-to-date management and KDIGO management of the IgA nephropathy patients. We know that we are behind, so she'll try to be very precise and give us just in 5 minutes the up-to-date management. Go ahead, please, Rasha.
I'm honored to participate in the course, and I'm going to cut it short, inshallah. My talk about the management of IgA nephropathy, I start by a very brief review about IgA nephropathy, but for the sake of time, I'm going to go straight forward to the KDIGO guidelines. So initial assessment and management of patient with IgA nephropathy, the patient has been proven to be IgA dominant. I mean, secondary causes of IgA have been excluded, like IgA vasculitis, IgA nephropathy secondary to IBD, liver cirrhosis, autoimmune disease, IgA dominant infection related to GM. So the kidney biopsy can be mixed score, and the patient risk is stratified using the international IgA prediction tool. If so, it's time to commence optimized supportive care. And optimized supportive care here means management of blood pressure with maximally tolerated dose of ACE inhibitor ARB with lifestyle modification. The KDIGO guidelines recommend that all patients have their blood pressure managed. So if the patient has proteinuria more than 0.5 gram per 24 hours, it's recommended that the initial therapy be either ACE inhibitor or ARB. And in all patients with proteinuria exceeding 0.5 gram, irrespective of whether they have hypertension, they should be treated by either ACE inhibitor or ARP. Proteinuria reduction to under 1 gram is a reasonable treatment target. For patients who have high risk of progressive kidney disease, and high risk of progressive kidney disease refer to those with proteinuria exceeding 0.75 to 1 gram per day, despite around 90 days of optimized supportive care. Here we can consider 6 months course of glucocorticoid therapy, and considering those who are contraindicated or should avoid the use of steroid, like those with latent infection, secondary disease, active peptic ulceration, and those with osteoporosis. The corticosteroid regimen used in clinical trials, either methylprednisolone or prednisone, with a dose ranging from 0.6 milligram per kg per day to 1 milligram per kg per day, with high dose duration for around 2 months and total exposure of 6 to 8 months. And for those who have risk of high progression, proteinuria exceeding 1 gram per 24 hours, despite 3 months of optimized supportive care,
those patients should be considered for enrollment in a clinical trial only if the eGFR exceeds 30 milliliter per minute, and if the risk-benefit profile is acceptable, and is not applicable for secondary causes of IgA nephropathy and not applicable to variant forms of IgA, like IgA with minimal change, AKI, rapidly progressive glomerulonephritis. And regarding the other immunosuppressive treatment, there is no documented evidence of efficacy. Apart from there is some evidence regarding mycophenolate hydroxychloroquine in Chinese population, which have shown to be non-inferior to standard glucocorticoid therapy and compared to placebo. But however, none of the two drugs has been evaluated in non-Chinese patients. Tonsillectomy as well, in the kidney guidelines, should not be performed as a treatment for IgA nephropathy in Caucasian patients. However, multiple studies from Japan reported improved kidney survival and remission of hematuria and proteinuria following tonsillectomy alone or with pulsed glucocorticoid. And finally, regarding the special situation, patients with IgA nephropathy rarely present with nephrotic syndrome. In these cases, mesangial IgA deposition can be consistent with a podocytopathy resembling minimally changed disease. So if the kidney biopsy revealing mesangial IgA deposit with light microscopy and electron microscopic features consistent with minimally change, we will treat as minimal change. And if the biopsy reveals a mesangial proliferative GM, it's time to treat as high risk of progressive CKD despite maximal supportive care. And for those presenting with acute kidney injury, if there is evidence of severe visible hematuria, supportive treatment will be the mainstay of treatment, and a kidney biopsy, a repeat kidney biopsy is considered if in patients who fail to show improvement within 2 weeks following cessation of hematuria. And for those presenting with rapidly progressive glomerulonephritis, other causes of rapidly progressive glomerulonephritis should be excluded, including vasculitis and GBM and so. For a kidney biopsy should be considered in this case, cyclophosphamide and glucocorticoid could be used according to the guidelines of ANCA-associated vasculitis. And my last slide. Regarding pregnancy planning, because IgA nephropathy is a disease predominantly of young adults, and all women of childbearing potential should be offered the pre-conception counseling regarding the management of IgA nephropathy. Cessation of RAS blocker should be considered, and in those who are at high risk for progressive CKD despite maximal supportive care, a trial of immune suppression to reduce proteinuria prior to conception may be preferable to emergent initiation of immune suppression during pregnancy. And thank you.
Thank you so much, Rasha, for this nice, precise presentation. I know that when it comes to obstetric nephrology, you are one of the experts in this field, and I like your last slide. Thank you so much for that. Again, nephrology is an art. We cannot just put everything in one basket and say IgA nephropathy is treated this way or that way. Even when it comes to RCTs, the inclusion and exclusion criteria are usually very strict. So in real life, we have to practice our art and use our brainstorming and our clinical judgment in treating our cases. Before we go to the last session, which is the quiz with Mahmoud Sobh, Dr. Peter Sawaya, do you have any comments?
I just want to follow one thing Dr. Sobh says, and I see it all the time. Is okay, we treat the acute phase, and often what we end up is a sclerosed glomeruli. And those, that's secondary FSGS. That, probably the #1 cause of secondary FSGS is a healed active GN, whether it's an IgA is on the top of the list. And we always so focus on proteinuria that we treat the patient with all kind of immunosuppression, and all what we have our hat to hang on is proteinuria, which again, I think a lot of time is related to the scarred tissue that has left us behind. And I don't know how we can get outside, doing a biopsy to see how much active disease you have before, but I see that a lot of problem, and that's the management that Dr. Sobh is saying, is going to be, that's where your problem is going to be, is the maintenance treatment of those diseases and how much active that you need to be. Again, aggressive therapy like this. That's the only comment I'd like to make.
Thank you, Peter, so much. By the way, Dr. Faisal Shaheen, feel free if you have any comments, feel free to unmute yourself. Dr. Faisal Shaheen is a professor in Saudi Arabia. He was graduated actually from Mansoura University many years ago. Dr. Faisal, please.
Thank you very much indeed. I enjoy all the talks actually. It is quite enriched, and we had a lot of patients now after doing biopsy for most of the patients presented with nephrotic and nephritic syndrome, and really IgA seems to be a big problem, and it was before not recorded how many patients we have in IgA, but I noticed recently that this number is increasing, and it was there, but it was missed because we don't have biopsy for every patient presented with nephrotic syndrome. Thank you very much. I enjoyed all the talk, and nice to see you again.
Thank you so much, and كل عام وانتم بخير. رمضان كريم.
وانتم بخير.
Mahmoud Soh is going to summarize the question and answers again and see if we have progress after this fantastic presentation by our knowledgeable speakers. Mahmoud, go ahead, please. Can you please unmute yourself, Mahmoud? We still cannot hear you.
Can you hear me now?
Yes, please. Yes, go ahead.
Okay. Here's our questions and answers. First question regarding treatment of C3 glomerulopathy. Which of the following is correct? The correct answer is B. Treatment with mycophenolate mofetil and steroid has been associated with improved rates of remission of C3 glomerulopathy in some observational studies. Second question, which of the following is correct regarding treatment of IgA nephropathy? The correct answer is B. Treatment with budesonide led to reduced proteinuria and improved estimate GFR in patients with IgA nephropathy. Third question, all the following are predictors of progression of end-stage kidney disease in IgA nephropathy except B, degree of IgA staining and inflorescence. Fourth question, the most characteristic pathological finding in membranous nephropathy is, the correct answer is A or 1, thickening of waste membrane with spikes in silver stain and subepithelial deposits in the electron microscopy. And fifth question, which of the following pattern of injury is most consistent with MPGN? The right question is E, duplication of the glomerular-based membrane. Sixth question, which of the following tests would help us differentiate whether MPGN lesion is caused by hep C infection or by overproduction of monoclonal protein? The correct answer is B, tissue immune fluorescence staining for kappa and lambda. And the final question, biopsy with hypocellular nodular mesangial thickening could be due to the following except mesangiocapillary glomerulonephritis. Thank you.
Thank you so much, Mahmoud, for this nice illustration. I think this was very informative meeting. I personally learned a lot from our professors and colleagues, and I like the thoughtful discussion and the contribution from both American and Egyptian side. Now I'm going just to do an announcement about the next meeting. The next meeting should be May 26 and 27. We'll meet to discuss the GN2 course. So that will include membranous nephropathy, RBGN, lupus nephritis, and ANCA-associated vasculitis. I know that these are very big topics, but hopefully we can just cover the up-to-date management in this condition next time. So please mark your agenda 26 and 27, which will be Thursday and Friday of May, last week of May. And it will be the same time between 4 to 6:30 p.m. Egyptian time. And we'll have another very, good speakers and contribution. By the way, this time we were planning to have our fellows attending this meeting from University of Kentucky, but they have their in-service exam today and this week, so they are not ready to attend, but next time, hopefully they can attend, so there will be more contribution from University of Kentucky side. I will finish. I will give the microphone to Dr. Nagy, Dr. Sobha, and Dr. Sawaya to, give final words and close the meeting for today. And kul aam wa antum bikhair.
Let me start first, Amr, thanking you very much for your effort. Actually, this meeting and previous one were very beneficial, and it is by your effort and your nice work. I would like to thank our guests who contribute a lot for the success of the meeting, and I benefit a lot from this, and I hope we will continue collaborating together in forthcoming meeting, inshallah. And good night for you.
Thank you so much, Dr. Sobh.
Yeah. Dr. Sobha, me.
Yeah, the big boss.
I'm very, very thankful for all of you, especially Amr. Actually, this is a very successful collaboration. It is a dream. Thank you all, a group of Kentucky and a group of Mansoura, Department 3. We learned a lot. We actually, it is very great, and hope it will continue, inshallah. Thank you.
Thank you, sir. Peter.
Yeah, I cannot thank you enough. I really cannot thank you enough. You put it all together, and you and Mahmoud and Dr. Sobh, it was really enjoyable. I mean, I thoroughly enjoyed it. And I tell you, it is just the launch pad to do some more of that. Now, geography is not an issue for any one of us. I mean, we wouldn't dream to have that. You used to fly to go back there, and now there is no excuse for us. And not only in a formal symposium like this, but also in our clinical practice. We all have tough cases, and we all scratch our head. And as we said, there is no right and wrong answer, but there is good judgment. There is good analysis what should be next for each case. So you can put one on the spot, that we put all the brains together and discuss cases as we go along, not to wait just for these major conferences.
Thank you so much. And hopefully we'll see everybody 2 months from now, 26 and 27 of May. And I'm sorry that we were a little bit behind. And kul aam wa antum bikhair. Please